So next we'll have Dr. Vincent Huang. He will take us deeper into the application of causal AI tools in family planning intervention. So Vincent Huang is the director of data science at AI at Circle Health, Public Benefit Corporation. At Circle, Vincent leads the efforts in applying data science and machine learning tools, such as causal AI tools, the topic of today, to behavior change in healthcare. Vincent has spent like over a decade experience in accelerating data science and analytic innovations in health organizations, ranging from Fortune 500 companies like Thomson Reuters to government stakeholders like the National Cancer Institute. And Vincent completed his postdoctoral fellowship at Columbia University Medical Center, and has a PhD in biomedical engineering from Johns Hopkins. And Vincent, the floor is yours.
Sorry about that. Okay, now I can hear. All right, so this is in Madhya Pradesh. It's about 90 million people. About 70% of the population live in rural areas. And the primary, so the forefront of the healthcare system are these community health workers that you see on the bottom row here. And they really are a gateway to all levels of public health services in rural India, as you see on the right here. So regarding to family planning, what's happening on the ground, right? So there actually have been a lot of investments from the government and others trying to increase FP access to new contraceptive. But you see in the middle here is that the family planning method mix actually is also quite skewed, just like our previous presenter. And specifically, there was an over-reliance on sterilization. And it created an unintended issue of it wasn't really addressing a women's needs on spacing pregnancies. There was another issue here, which is they're supposed to be having, to really activate all sort of channels, but really there wasn't a lot of, but in reality, that just wasn't the case. And then you see that, so what happened was that the overall amount of contraceptive use is still remain very low, despite decades of investment. So where do we fall short, right? From the analytics perspective. So we can have a lot of data, but the problem we have is that with the observational data, we did a lot of correlative studies. And as we know, like correlation doesn't imply causation, and that can lead to misattributions of certain predictors and attributing that to particular intervention target. And one example here, for example, is that we ran a particular model and we saw that was inclusion. Being a member of self-help group, which are these age group of women that sort of teach each other how to regarding information about family planning, but also others as well, being a factor, right, for family planning uptake. But it could also be age, right? These tend to be like older women, and there could be other confounder as well. So the end result is like you don't really know like what are the right interventions to implement. So I think this is where the potential of causal AI actually can come in. So number one, a lot of data that we have is observational data. So right off the bat, there is an advantage there. And causal AI can really sort of show you what are the top candidate target interventions points that you should make. And if you are going with a structured way of assessing these interventions, you actually have additional information regarding how to make the intervention. And we can also conduct virtual RCTs. And the idea of these RCTs is that you can now compare multiple different interventions and then look at the different ROI for different interventions. And hopefully that allows you to sort of quickly narrow down the efforts and allocation of resources on those priority interventions. So when I talk about causal structure model, what I mean is this specific type of model called the causal Bayesian network model. And it has two components. So in the center here, you see this is just the general structure. And the structure consisted of nodes where like these A, B, C, and D, and it has these directed edges, which depicts the directions of influence. And these type of graph is called the direct acyclic graph, and it can be learned from observational data via different kind of structural learning algorithms, PC algorithm, greedy equivalent search, and so on and so forth. I include some citation at the end that you can kind of look this up. The other components of causal Bayesian network are these conditional probability table for a discrete model. And this is simply the frequency of observing an outcome or any variable state given its conditions of the parent. And you can learn these simply by maximum likelihood estimates or Bayesian posterior estimators, right? So that's relatively straightforward. Now, so when we talked about virtual RCTs, what are we thinking? So if you think about the actual real life RCT, right? What happens is that we're trying to solve this issue, right? On the left here. So you have a confounder that's actually influencing two variables, right? And then if you happen to not taking the confounder into consideration, you see this spurious association, and that's the big problem. And what randomization of assignment of treatment does is that it will dissociate that relationship between the confounder and the treatment, since you are the one who's actually trying to assign in who gets the treatment or not randomly. And that's equivalent of taking that structure and just cutting out all the influences going to the treatment, because since you are the one who's actually assigning the treatment. And we call that kind of procedure a graph surgery, and the resultant model is called the manipulated graph. And you can do this by for any of the treatment variable that you're interested in. So that's what's convenient about it. So if you actually have a graph, you can actually do this for every single one of those potential treatment upstream variables, like those variables upstream to your outcome, right? And so what you can do then is to estimate you can infer the outcome posteriors by each one of these interventions, and then you can rank them by the amount of effect. Now you can do this multiple what I call the virtual RCTs, and quickly you have a way to kind of compare interventions in a very systematic way. So one of the assumptions that we make when we learn and infer causality is this assumption that all the common causes are in the data, and this is the same for different kind of framework across the board. So I think it's important to point out, right? Data is actually quite important to mitigate this failure, right? Potential failure is to try to make sure that in your data that you account for as many confounders as possible. I think this is where having a systematic way of collecting data makes sense. At Circle, we use a framework called Cubes, and it's really looking at multiple dimensions of what the influencers and what are the perceptions and what are the contextual factors that goes into people's behavioral decision. So that's the data that we tried to collect in 2019. So we went in, conducted a very comprehensive survey in MP India, and this is the data we use to learn our model. So here's the model. Right off the bat, you can see it's quite complex, and it has several influences come to the outcome, which is the MET. And you'll see that there are several direct causes, and these are the pillar or target of interventions, right? So things like awareness of AP locations, awareness of the methodologies, and having given the AP counseling after their last birth. But what I'm pointing out is that there's also additional information in the model. So it allows you to kind of help you define what the intervention should be designed, So a couple examples. So for example, we look at awareness being a direct driver of uptake, but who should do that, right? We saw that there is paths that that directly are influenced by the community health workers. So that becomes a central point in when we talk about intervention design. Similarly, we saw that concerns with the safety of these methods, right, is also core and upstream to the uptake. So when we are talking about messaging, we need to integrate that as well. And this sounds very intuitive, but in actuality, it's not, right? Because at time the programs actually have a lot of focus on couple communications. So and also that the community health workers, even though they're active, family planning isn't like the top of their list to talk about. There's a gazillion things that they have to do. So having this kind of knowledge and information allow you to kind of redirect and then refocus your intervention. We can also do these virtual RCTs, as I mentioned earlier. And what we can do with this is now we have this ranking of these posteriors, then you can look at what are the top intervention, what are the targets, and how can we bundle them together to create impact. And what I want to kind of point out is that the model that we did, we estimate about 9 percentage point increase over control if an optional, if the optimal intervention was implemented, which was trying to get the CHW engaged with the women with proper material. So what we did then is trying to validate this in the field. So we conduct a cluster RCT in the following year. And as any program officers here will know, is that just knowing like what to intervene only get you so far. So you really still need sort of participatory designs and trying to understand how to actually bring this to reality. So we did that. And the intervention is looking, these participatory designs, they help us kind of understand, like, for example, the frequency of engagements, what kind of materials and structures that we need to provide during these interventions. And we do have these gain in community health worker activity when we did the intervention. As you see, between the intervention between the treatment arm and the control arm, you see that we get a little bit increase in terms of the frequency of visit. But what's really different is how much they actually discuss about the family planning. And if you control the uptake, we see a 3x, right, going from 6% to 18%. And if you compare treatment and control at the baseline, we saw 8.34 percentage point. And just reminding us, like, that 9% percentage point that was estimated, this is very, very close to that number. So what kind of impact did we have? So arming with the results, the government is now considering scaling this intervention across all 52 districts. And also locally, all the community health workers, they are reporting that the material that we created are truly beneficial for their engagement with the women. And also now there is an award that was awarded to Chai from the United Nations Population Fund to actually do this in a more deeper way in 3 focal districts. So to summarize, I think what we have done here and what I'm trying to convey is that it is an approach that allows you to go from end to end, right? So really thinking about causally what intervention levers that you can target and guide these designs with this more system view of all these different influences that can actually contribute to the final outcome. And finally, armed with this kind of information that allow you to be a little bit more efficient in allocating the limited resources that you have in actually conducting these tests and hopefully really scaling up the impact. So I'll end there and open up for questions.
Thank you, Vincent. Any questions from our audience? Go ahead. Oh, Michelle, you're next.
user interface for the policymaker. I mean, to be able to inform the policymaker, this is a target intervention they need to put in place without the back end process of the modeling for this to be scaled up maybe to other, policymaker to really understand and use that tool to make decisions. Do you have that? And then the second question is on, can this model be used in other geographical context, or is the data specific for that particular community in India?
Yeah, thank you. So I'll try to answer your second question first. So we are trying to do this in other contexts as well, right? Your question is about generalizability, right? Are these, and I think it because the data that you use are usually fairly context specific. It may not work always from one geography to the other. However, I think if you have enough similarity, right, in the geography, then I think you can start exploring what are the common potential causes, and that certainly is one thing that we're trying to do. And your first question, apologies, was about policies. Yes. User interface. When you talk about user interface, do you mean sort of like a dashboard or some sort, or things like that?
Yeah, something like that.
Mm-hmm. We could, but I think as you can see that forest graph, right? I mean, it's pretty simple. So the question is whether if it actually makes sense to devote resources to actually design a dashboard like that, when I think the top line is pretty easy to communicate. Had I think the system that we're trying to model be even more complicated, I definitely see a use for that as well. I think one of the benefits of having this type of modeling is like, I don't need to list a lot of numbers, right? So I think having that kind of visual map allow you to kind of, hey, if I want to influence this point, all I have to do is kind of just trace back and then have that narrative, which is very useful.
Very short question. Thanks so much, Vincent. Nice to see you. I have seen versions of this maybe half a dozen times, and I think I'm finally convinced that this is like a real thing. But one of the benefits is that you collected the data that really covered all of those upstream aspects, right? Yeah. And then you were able to validate it with a cluster RCT. So in terms of scale, so this is another sort of scale question. Yeah. If you took this tool and you, for instance, I want to use it on DHS, where we don't have all the comprehensive data that you need. How do you think about data scarcity, and can this tool be sort of modified to account for that kind of uncertainty, right?
Yeah, absolutely. And I think you and I discussed this earlier too. I think in general, because I don't want to just talk about family planning, but in general, it's about what are the relevant confounders that you include in your data, and whether those important confounders exist in your data in different settings, right? If they are, then I would be more confident to say, yes, the results is directly translatable. Otherwise, you have to do some work in kind of figuring out what's actually missing in the new data set. So things like DHS, PMA, that sort of things. I think that's where we're trying to think about. I mean, you're absolutely right. Like scaling is important, but identifying what are like the true causal variables and all the contextual variables that are truly relevant. You may not need all 200 variables in the questions. You only need 3, and if you have that 3, then you're good, right? So that's kind of the scenario we want to get at.
Thank you, Vincent, again. And we have one last question towards Vincent.
Yes, thank you for your question. I think that's important to know that you're just reminded. So your question is how is the method I introduced different from the other alternative methods? And I think a core feature of this approach is that you are essentially agnostic about the determine or the generative process of all these different things are interacting with each other to come up with a particular outcome. Versus, I think, in a model, whether if it's agent-based or others, you kind of look through the literature, you kind of rely on those information, that domain knowledge, to write down your equation, and then you put those equations together to make a generative process. So I think that's one core difference. But I don't want to say that one model is better than the other, because I think, for example, ABM has a fantastic feature of modeling the dynamics of different population, different individuals in a very longitudinal way, right? So even though I think easily presented data in sort of kind of a snapshot, but in reality, there's actually a lot of dynamics that it's really hard to actually represent, but those are really important when we are actually implementing intervention. On the other hand, the type of modeling that I was presenting, right, allow you to sort of let the data speak for itself on the sort of the causal relationship of the different variables. So I see maybe perhaps there is this complementary usefulness when you are actually taking different approaches.
Thank you so much.